The topic for today is blood pressure effects of sodium reduction. It's common knowledge that limiting salt intake has positive systemic effects, especially including the cardiovascular system, and especially on the maintenance of blood pressure homeostasis. Recent clinical studies are putting a scientific focus on this relationship. And Dr. Gonshor, take it away.
Well, thank you, Reed. And as I always say, in each of these sessions, we take a deep dive into recent research, and we really try to make it very recent, and how that brings to light objective scientific evidence on whatever the topic at hand happens to be. And today we're looking at blood pressure effects of sodium reduction. And this study is actually very important because it is clearly showing that there is a positive linear relationship between sodium intake, between salt intake and blood pressure, even in the long-term trials. Now, this means that a progressively large reduction in blood pressure can be expected with decreases in sodium consumption down to even very low levels, with no evidence for a threshold in that benefit. So, with that in mind, let's look at the actual evidence because science matters.
After our last broadcast, which was titled Persistent Complement Dysregulation with Signs of Thromboinflammation in Active Long COVID, very popular topic these days, and there were some questions that came to our attention. One of the questions was, Dr. Gonshor, Science Matters has had two broadcasts in the last few months dealing with long COVID. Can you please summarize which coronavirus patients are most at risk for developing long COVID?
That's a very good question. And I want to begin by actually saying that COVID is still with us, guys. In case you were wondering, that coronavirus is around, it keeps mutating. Thankfully, it's mutating into a less aggressive state, etc. But I don't want there to be any misunderstanding about this. COVID is around, and long COVID is around as well. And we really are just beginning to get a look. We're opening up the window slightly to see what it's doing to a whole number of organ systems and hormonal function and so on. And so long COVID, in effect, refers to a wide range of symptoms and conditions that some unfortunate individuals experience when, if for 4 or more weeks after an initial infection with SARS-CoV-2, the virus that causes COVID-19, that's the one. If you're starting to have symptoms more than 4 weeks after, you probably have some form of what we're calling long COVID. And these symptoms, conditions, they can last for weeks, months, and as we are unfortunately now seeing documented, it can persist for years. But what causes long COVID? Well, there's a recent report, which I'm going to be looking at here with you for a few moments, by Yale Medicine. It suggests that while the causes of long COVID are not yet known, researchers and clinicians have started to propose several possibilities, which include, number one, the remaining virus. Now, this theory has been around for a long while. It suggests that after the immune system eliminates the coronavirus, some remnants are surviving in one or more organs, and it continues to stimulate an immune response. And the immune response may damage tissues and result in chronic inflammation, which then leads to long COVID symptoms. Now, remember, you can also have as a possibility the reactivation of latent viruses, and we know about this. Some viruses, for example, in the herpes virus family, such as the Epstein-Barr virus that causes mononucleosis, can infect a person in the past and it remains in the body in an inactive or dormant state. And there is evidence that in people with long COVID, these inactive viruses reactivate, and this may cause long COVID symptoms. Another theory is an autoimmune response. According to this theory, the immune system produces antibodies that target and then attack a person's own organs and tissues. And this includes two components that we discussed in the past few months on Science Matters. One is the complement system, which we just discussed several weeks ago, as well as the cellular mitochondrial damage. And if you go back a few months ago when we did our first one on long COVID, we discussed mitochondrial damage. And both of these lead to cellular dysfunction. And ultimately, if that cell is in a dysfunctional state, depending on the organ that it's in, that organ is going to suffer and you're going to feel the effects. And what are those effects? Organ damage. The symptoms of long COVID may be due to damage to the organs and or the tissues. And that's being caused by the body's immune response or continued immune response to the SARS-CoV-2 infection, the reactivated one, the one that has come out of a dormant state, etc. So long COVID may be caused by a combination of these and other factors, and investigations are still underway to better understand long COVID, and there's an awful lot of research that is still necessary. And that's my
And I'm
take.
sure we're going to be running into it. Thanks so much, Dr. Gonshor. It reminds me, this is like there's bad news and there's more bad news. Like you have COVID, it hasn't really gone away. And oh, by the way, that herpes that you have, that's been reactivated too. So yeah, it's a problem. And in a way, I don't want to say it's good for business, but what I mean by that is that there's lots of people to dedicate yourself to, and you could niche in this area. It's a wonderful thing for us in the FDN world to be very up on top of, because people are going to show up with this problem.
And can I just mention one other thing? And I'm just going to mention, I know you and I have talked about it, Reed. Adrenal insufficiency. There are a number of studies, and I'm actually going to send it out to the group. Maybe we'll do a session on it.
Okay.
Long COVID turns out to cause adrenal insufficiency, and it can be very significant. What's produced in the adrenals, and with this I'm going to finish, cortisol, amongst other things. Well, well, well. And so we will discuss this at a separate issue, but just remember, adrenal insufficiency is also a result of long COVID.
Yes, sir. And I want to thank everyone for submitting your questions. They're very important to all of us as we learn together. And thanks, Dr. Gonshor. Now let's jump into today's study about blood pressure effects of sodium reduction. Dr. Gonshor.
Well, thank you very much. Happy birthday! This is our 1 year anniversary. We've been at this for 1 year. And literally, I believe on the June the 14th of last year, we had our first Science Matters. And so I know I speak for Reed when I say how humbled we are by the response that we have received from FDNers and from others who've come on and continue to come on in increasing numbers. It's wonderful for us. It's just a way of making us feel that what we're doing is being appreciated. Thank you to all of you, and happy birthday, Reed.
Fantastic.
So, blood pressure effects of sodium reduction. Well, what do we know about this? Well, this is a study that came out very recently, and it talks about the blood pressure effects of sodium reduction. It's a dose response meta-analysis. So they're actually looking at the various doses and how is that going to affect any number of things, especially blood pressure. And what they're saying is that in this dose response analysis of sodium reduction, read SALT, they identified an approximately linear relationship between sodium intake and reduction in both systolic and diastolic blood pressure across an entire range of dietary sodium exposure. So what does that mean? Well, let's take a look and see what it means. Well, as some background, high blood pressure one sees in about half of US adults, and that is not a good sign. Of all the diet problems, and we've got many in North America, sodium is considered the most harmful to not only North American health, but global health. Excess salt consumption, I'm going to repeat, sodium chloride is salt. So excess salt consumption is shown to cause about 2 million deaths per year worldwide, mainly due to cardiovascular disease, which of course includes high blood pressure and failing kidneys, etc. In the US, approximately 95%, almost all men, and a good number, over 75% of women, consume greater than 2,300 milligrams per day, which is the limit that is considered by in US dietary guidelines of what you should be taking in. That's about a teaspoon of salt. And they say you really shouldn't be taking more than that, and keep that 2,300 milligrams. That's about 2.5 grams per day. The average adult in the US consumes greater than 3,500 milligrams of sodium per day. So, given that the 2,300 is considered the limit, that means that 3,500s can be challenging to cut back to 2,300 without making, folks, drastic dietary changes for many people. In the US, approximately 70% of sodium that's consumed comes from processed foods and dining out. I have no problem in people dining out or eating processed foods. We're just eating too much processed food. So the best way to reduce sodium consumption is eat less of these processed foods, and as much as you can, cook more at home. When buying packaged foods, choose products with no more milligrams of sodium per serving than the calories. That's a way of knowing that you're okay. So I'm just throwing that in. Studies in the last 50 years show there's a clear pattern. The greater the amount of salt that's taken into the body, the greater the blood pressure. That's not new. Those studies, there are hundreds of those studies. In 2021, there was a review of 85 clinical trials. They wanted to know what happens to blood pressure when you consume 400 to 7,600 milligrams per day of sodium. Well, as consumption increased, so did blood pressure. The effects are strongest if you already have high blood pressure, of course. But even in people who don't have blood pressure, it starts to increase. There was a 2022 analysis of over 10,000 adults that were followed for close to 10 years. And they consumed that limit and above, twice the limit that they're supposed to have per day. Those who consumed the least amount of sodium had the lowest risk of cardiovascular disease. And as sodium consumption increased, so did the cardiovascular risk increase. That's established. We've seen that in numerous studies. This study had 85 eligible trials. The sodium intake was from 400 to 7,600 milligrams per day, and they were followed for anywhere from 4 weeks to 36 months. So that's up to 3 years. And remember again, in the US, almost all males and females are consuming greater than that 2,300 milligram per day limit. So most of us are above the level where we should be. The trials conducted in participants with or without hypertension. And the results, overall, the pooled data was compatible with a almost linear relationship between sodium intake, and the mean systolic and diastolic blood pressures, with no flattening of the curve at either the lowest or highest level of sodium exposure. That's very interesting, because that means if you keep decreasing your sodium exposure, you have a chance of really continuing to decrease your blood pressure. And worse, on the other end, you keep taking in sodium and your blood pressure will continue to go up. And remember, it's not just about systolic. Diastolic is even worse, because if you increase your diastolic blood pressure, that is a major problem for cardiovascular disease and stroke. So there's little influence on blood pressure effects of sodium reduction from the following: the intervention duration, whether it was greater than 12 weeks or less than 12 weeks, the type of study design, was it parallel or crossover, where people were given different, they did a certain thing for a period and then they switched. Didn't matter what you did. Or even the use of antihypertensive medication or the participant's sex. None of those things really affected what we're talking about: sodium and blood pressure. So what is the conclusion? There's a dose response analysis of sodium reduction in clinical trials. And what does it identify? An almost linear relationship between sodium intake and reduction in both systolic and diastolic blood pressure. Bring down your sodium, you bring down your blood pressure, and that's across an entire range of dietary sodium exposure. Although this occurred independently of baseline blood pressure, the effect of sodium reduction on the level of blood pressure was more pronounced in participants who started with a higher blood pressure. So if you have a person who's already hypertensive, get their sodium level down. You're going to be doing them a world of good. And by the way, they have wonderful graphs of blood pressure effects on sodium, and it doesn't matter what you were looking at, all the studies, different supplements, diet, the amount, it doesn't matter. You saw a close to linear relationship. So what are the takeaways and the clinical implications? A linear positive relationship exists between sodium intake and blood pressure, even in the long-term trials. It means that a progressively large reduction in blood pressure can be expected if you decrease sodium consumption down to levels as low as 1 to 1.5 grams per day. That's well below that limit that I was telling you, with no evidence for a threshold in the benefit. That's great. So advice to reduce dietary sodium intake applies not only to adults with hypertension, that means already high blood pressure, who can be expected to derive a substantial reduction in blood pressure, but also to those without hypertension, in whom the expected reduction in blood pressure is smaller, of course, because they're not hypertensive, but still important. And with that, it's the end of that particular story.
Well, thank you so much, Dr. Gonshor. That was very informative, and a lot of this stuff we think we know. I would also say that sodium is an essential mineral and it plays some crucial roles in the body, but we're being inundated with especially if you eat any kind of commercial foods, you're going to get 1,200, 1,300, 1,500 milligrams just in a fast food sandwich. And it doesn't matter which, it's why I haven't eaten it in over 20 years. But very, very important to keep it down. And this also puts the power in the hands of the people, because you're talking about reducing blood pressure, which is very bad for you yourself. No medication, unless you don't behave yourself. And so I think it's wonderful that we can put power in the hands of the people with this kind of information. And so I want to thank everybody again for submitting questions. I know we'll get a couple on this topic. And we want you to know or say subscribe, like, and share if you've enjoyed this episode. And apparently you guys like us because our listenership on YouTube has gone way up. So thank you for that. And we're going to keep doing this. So submit your questions, comments, and suggested topics to www.fdntraining.com/science matters. And you can also grab a copy of the studies at fdntraining.com/studies. And as you know, and I've been closing my segments like this, in a world propelled by science and technology, understanding the fundamental principles of science is no longer just an advantage, it's a necessity, especially for us. To thrive in tomorrow's world, become equipped not just with scientific knowledge, but with the ability to critically engage. Grab the scientific literacy course offered by FDN at fdntraining.com/smliteracy. And join us again in 2 weeks on June 26th when we'll talk about, and we're starting our second year. Fantastic. Yee. So the next Science Matters is going to be about a distinct Fusobacterium nucleatum clade dominating the colorectal cancer niche. It's very, very interesting study. It's a big one. And why do we do this, Dr. Gonshor?
Now I'm going to let you say it, Reed.
Because science matters.